Megan Crapier. So Megan has some issues going on. And so remember, earlier we had someone in the class who's confident in doing an examination. Today is the day, okay? So we've gone through upper extremities. We just got to lower extremity. So whatever you have going on upper extremity may be the best thing to voice to the student therapist and to see if we can find out what problems that we could likely address. How does that sound? Okay? But Megan's gonna give her history. She has a lot going on, but ultimately we'll let Megan give her history, subjective history, but ultimately we'll zone in an area where we've been first.
All right, my name is Kendall. I'll be your student PT today. Just tell me a little bit about like what you have going on. Do you have any pain, any restrictions that you notice? Just what do you think happened?
So I have a lot of chronic conditions. Firstly, I have hypermobile spectrum disorder, but my rheumatologist said it could be hypermobile Ehlers-Danlos syndrome, but there's not really a way to confirm it, is what she said. But I hurt my shoulder a few years ago playing lacrosse. I was intercepting a pass overhead, and then my shoulder popped, and it just kind of went limp, and I drug myself off to the side of the field and cried about it a little bit. But I guess it's fine now. It still pops sometimes. And I also have thoracic outlet syndrome bilaterally. I think it's only vascularly, but I do have neuropathic pain, so it's probably both. And I've been told I have cervical dystonia in my neck when I was 15, so I have a lot of migraines and neck pain and muscle spasms.
Okay. What are some of the motions that you feel the most restricted doing? Like, do you have any problems reaching overhead or?
I don't necessarily have problems doing it, but reaching overhead sometimes my hands will go numb if I do it for a long time, and it'll make me a little bit lightheaded and dizzy if I'm like doing something overhead for a long time.
I guess like what are your major concerns or problems that you're having right now? Or what are you seeking to get from physical therapy?
I guess mostly to find out how I can like live life and exercise without going over my range of motion limits that should be there that my body doesn't listen to.
Do you have any other extracurricular activities that?
I knit and crochet a lot, and that does definitely make my hands hurt and go numb.
All right, so you would say like your main goals would be just to improve like your range of motion and kind of decrease some of the pain that you're having with the activities that you like to enjoy. Okay. And you're having the most problems with your right shoulder.
Mm-hmm.
Okay.
Well, I had a previous injury to it, but the thoracic outlet syndrome is bilaterally.
Okay. Well, we can start. I'm gonna assess some of your range of motion on both of your shoulders just to kind of see where we're at with it and just get a baseline as to what you have right now and then where we would need to be.
So I'm gonna interject. You're doing good. If you had to choose a region of your body, and we typically think in upper extremity, so if you had to choose a region of your body to be examined today, which region would you choose to be examined?
In upper body would be my right shoulder, but in general my lower back is you said upper body. So.
Okay, so, all right, so shoulder, right shoulder.
Right shoulder.
All right, thank you.
All right, you can go ahead and hop on the table and just lay on your back.
So since the extensional knee is about to assess your shoulder range of motion, I'm gonna remove the pillow so that it doesn't block your range of motion. Go ahead, start like that. So when I assess shoulder range of motion, I always remove the pillow because I don't want the pillow to block the range of motion that the person may be able to achieve.
You can just kind of be dead weight. I'm just gonna take you through some passive range of motion, so try not to restrict any of the motion there. Any pain with that?
So which side is the right side your involved side? So start on that non-involved side.
And this is still pain-free.
So while you're doing that, I'm gonna jump in.
Not painful. Now it's gonna take some ranges with the average.
So before you take your ranges, now I'm gonna interject. All right, get a gross assessment first and see what she presents with. So just ask her to do it first before taking your ranges.
Right.
So let's start with the non-involved side. So Megan, on your left side, I want you to make this motion right here and go back as far as you can. That's shoulder flexion. All right, come back. Can you do the same thing on the right side? All right, come back. Now, go out into abduction, like playing in the snow, doing angel wings. Take your arm up into abduction for me. All right, come back. Go ahead, do the same thing on the opposite side. All right, come back. And now, I want you to actively do external rotation for me. Go as far as you can, and then actively do internal rotation. External rotation. Do that on the right side for me. Okay, I'm just eyeballing. I'm saving myself time. So I'm not about to measure all this because I only got so much time. So I'm eyeballing it. And with my documentation, for all of those, I'm writing within normal limits because I'm quickly eyeballing it. I know what I see. And so now that I already got my end fields, do internal rotation for me. Now, I'm notating internal rotation. Maybe didn't go as far as she could. So I got my passive range of motion in my end field for those. And both of my end fields for those were abnormal firm end fields. Okay? And so with internal rotation, you got an anterior glide, internal rotation, anterior glide swing with a posterior roll, right? So now I'm thinking posterior joint capsule tightness, all right, based off of that. So what I'm gonna do now to save myself some time is I'm gonna measure internal rotation, active range of motion, and write both of those down.
this is the motion that I want you to perform, the internal rotation.
She's going as far as she can.
Start at 0. Alright, you can go ahead. Is that all you have? Alright. I have 0 to 76 degrees. Alright, same thing. I have 0 to 75 on this side. So I'd say they're both relatively the same.
Okay. So far, eyeballing her active range of motion bilaterally is pretty much symmetrical with flexion, abduction, external rotation, internal rotation, and I assess passively horizontal adduction and abduction. So far she's been symmetrical. So nothing has jumped out thus far except for the tautness on both sides with the end feels. And so that's gonna direct me, right? So now I wanna see what her accessory motions feel like. So go ahead.
So I'm just gonna apply downward force on the humeral head.
So make sure your angle, your line of force is in line with your forearm. So come across her body. Good. Try that again. There we go. Why am I putting that up under there? So get a good comparison of what you feel. And she got so much external rotation, I'm not even gonna waste my time with assessing the anterior glide because I know it's going that way. That'll be a waste of my time.
So because she's hyper, would you still say that's within normal limits, or would you document as that is something else?
I would document within normal limits, but I probably would document hypermobility noted as well because she went way beyond normal. And that's gonna clue me into my interventions as well. So I'm not even, most likely I'm not even gonna be thinking joint modes. It may be more so working on stability.
So that would be considered an anterior instability because it has too much anterior glide for external rotation.
And I'm not gonna say this, I'm gonna say hypermobility. So I'm not gonna directly say instability because she may not be, she's not sublux or dislocated.
I think they felt the same.
Okay.
Maybe like slight hypomobility, but I wouldn't, it's not too much.
Okay. So
Almost normal.
okay. So now we'll move on to MMT, MSTT.
Can you come in towards your body a little bit, but go about halfway? All right, I want you to hold that position and don't let me push you in. Okay. Same thing this side. Do you have any pain in your normal?
Okay.
Function.
So test her internal rotators. Test her subscapularis
Out.
and teres major.
Okay, come out for me. Hold that position on me. Is that right? Great. Other side. Hold that on. Any pain in that?
Okay, test her supraspinatus muscle.
Can you bring your arms out? Turn them down. Hold that, don't move. Any pain in that?
test her. So now go look at her scapula, assess her scapula position, and let me know if you see any wing or anything. So why am I saying assess her scapula? Because now that's gonna let me know if I need to assess dynamic scapular stabilizers. So like serratus anterior, serratus posterior, rhomboid muscles, upper trapezius, lower trapezius, all of those your scapular dynamic stabilizers. But if she presented with any winging, I would transition to assessing those. But if not, I'm crunched for time, so I'm using my knowledge and my time wisely. So now I'm gonna go to, so now I'm gonna use her subjective information. So she said it pops sometimes, and she feels popping, right? So now I'm gonna assess her glenoid rim, her glenoid cavity.
I think it's the grinding and the.
Grinding, clump, crank.
So first I'm gonna do the grind.
And you listen for any popping, clicking or clunking, any reproduction of pain.
Do you feel any? Clicking, popping? You still don't feel anything?
Now halt right there. Now with that, add an anterior movement of the humeral head. So bring her back right there. She's externally rotated. Now, what am I doing? So I'm gonna come right here, get her externally rotated, get her right here, and now I'm lifting the, oh, there we go. See, you gotta add every component of the test. You see, what did I just do?
Brought it up.
Where's test is at?
Yeah, that's clump. 'Cause the first one
It's the clump. So boom, oh, I got it right there. So let's see. I'm gonna come over here and compare. So I got it externally rotated, then I'm gonna provide. So I'm not getting that over here. I'm not getting that movement. So over here, I don't feel that. So she reported a pop sensation, right? So I'm gonna come back right here and assess that one more time. This is why you gotta know these special tests and be able to go through them smoothly. Ooh, you can even see it. So now, keep going. So you did the grind. So with the grind, let me go back. Because you probably could have been a little. Come in here. Any pain or discomfort with this? Okay. So now, use your form to help me. Oh, I got something right there. Any pain, discomfort with that? Okay, but I did feel abnormal movement with that grind. Felt like it popped. It did something weird. Sometimes you just notate in your mind. Any pain, discomfort? Okay. Could just be, I noted it on this side too, but it was very subtle. It was more pronounced on that side. So it could just be something dealing with hypermobility, but I'm gonna come back to that because that clump test, that was significant in difference of what I felt. All right, keep going.
Um,
Let's do O'Brien.
No, that's Hawkins County.
You can do O'Brien with her just like this, with her internally and externally rotated.
Is it normally she's like sitting up?
Normally the person's sitting up or standing, but I do things, you can still do it with her like this.
Okay. Can you bring your arms out to the side?
I'm just using time.
Like point your thumbs down.
Now you just gotta provide the resistance.
So hold that on. All right, now this one. Hold that on. Any pain with that or either one?
Now I'm gonna do internal rotation, come across the body.
Okay.
So we do like this, come across the body, internal rotation.
Yeah. So turn your thumb down and go across your body.
Now try to pull her down.
Any pain?
a little bit.
She said a little bit. That is, okay, yeah.
Do your other. Any pain?
A little bit.
Get it, come across your body a little bit more. There we go.
Any pain with that?
Just a little bit.
Was it
Sounds
more
like
on
I
that
heard
side?
something. Did I hear something?
That might have been a smack.
Okay. All right.
I pop a lot.
Okay, you were just popping. Okay, do the other side again. Come across the body a little bit more.
So same thing. Pain down. Do you feel any popping or
Any pain?
a little bit?
Same thing, but externally rotated.
So, yeah. Anything with that? Same thing.
Okay, all right. So, I got something going in my head. You should have something going in your head too, based off just those special tests. Now, you know what I'm gonna transition to? What do you think I would do next? I would do some apprehension tests.
I need a towel. Slide towards me just a little bit. I was gonna do this one first. See this over. Is this painful at all? Slide back over. This is super painful.
This is very, very light.
Nothing here.
I mean, a very little bit towards the end.
Okay. Feel anything with that one?
Okay. So when you did her apprehension test, what did you do? Did you bring her anterior or posterior?
Anterior.
Okay, I'm gonna check. Okay. Any pain with Is discomfort with that?
A little bit, but just not really enjoying.
Okay, not even joint. Okay, discomfort with that.
Not really enjoying it down.
All right, scoot up toward me. Anything discomfort with that?
A little bit, but not really enjoying it.
Okay. All right. Okay, I'm assessing pectoralis major, muscle length, anything.
Just down my arm.
What's it going down your arm? What do you feel going down your arm?
Like a stretch, I guess, or just pulling, kind of, but it's like.
Like a stretch? Okay. Do you still feel the same thing, like a stretch? Okay. These techniques I haven't showed y'all yet. This is I'm sensing the length of her biceps, brachii, short head. Okay. Right. Ooh. You feel that core process pop into my thumb? Okay. So you still feel that tightness? So that indicates a tight biceps brachii short head. As soon as I took you to the motion, your core process, which is what a short head attached to, that popped into my hand, which lets me know that that could be a problem muscle. Okay, now I'll come back right here. Find your core process. Clavicle drop right here. I saw you wince. What are you feeling?
Just pressure on that bone.
That's the core process. But I'm assessing the extensibility of your pectoralis minor muscle. Now I'm going to soft tissue. I haven't shown y'all a lot of soft tissue assessment. Okay. Now we're gonna come back to special tests. I'm gonna have you assess her for thoracic outlet syndrome with special tests. So right here on the core. Any pain, discomfort? Yeah. This pectoralis minor muscle is tight. So your pectoralis minor muscles are tight, more so on this side. It's very tight. Your biceps short head is tight on that side. Your pectoralis major muscles, they have good extensibility. Now, I'm gonna do something. Okay? You don't like that?
No.
You try to move away from that. All right? This comes from clinical experience. All right? So I see you wincing. You don't like that. Okay. I see you wincing. You don't like that? Upper trap, scaling. So I'm going to this because she said thoracic outlet syndrome, right? So now we're going to assess the structures that if they're taught, they can contribute to thoracic outlet syndrome. I see you wincing. Okay, but not as much startle response on this side than the other side. So I'm posterior scalene, middle scalene, and interior scalene. All right, turn your head to that side for me. Any pain, discomfort? Yeah, this muscle, her sternocleidomastoid, is pretty lax. All right, turn your head to the other side for me. Any pain, discomfort?
A little bit.
A little bit. So So right sternocleidomastoid, I'm in here grabbing, I'm not afraid. And she's coughing, or she's wincing, so that could use some work. I don't neglect my palpation exam because it gives me information. Okay, now, all right, I'm about to depress your first rib. This is gonna give me information as well. Any pain and discomfort with that? Mm-hmm. So decreased mobility with first rib. Any pain and discomfort with that? I see you wincing. All right, so I just found a lot of problems with my hands. Okay, so now, let's go back to thoracic outlet syndrome. So do some thoracic outlet syndrome tests and see how those come out.
You were also testing the tonsils, but were you also like compressing to see if it would reduce symptoms?
Oh, what?
You were testing the tonsils for muscles, but you also kind of like compressing to see if it would reduce symptoms.
Yes. So I was assessing those for nociceptive startle response, meaning if they have active trigger points, the patient's gonna move away from them. She's not gonna like it. And so that's why I assess the upper trapezius too. So let me come up under here. In the pain, so I see she's wincing. So this is my palpation exam. In the pain and discomfort. So, but in the rhomboid area, right there, and when I go to infraspinatus, nothing. Okay. So really like a rhomboid middle trapezius problem. I know what to do for that though. Anything right there? All right. Now, ooh, that's crunchy. You know what that is?
This is a trigger point.
It's levator scapular muscle. Your levator scapular muscle needs working on. That's very crunchy. You feel that? This side, ooh, feel that? That's a problem. That's very ropery, crunchy, feel like a nodule right there. That's a problem. So this palpation exam, finding problems with my hands now. So once I go through all those other things that Kendall did, okay? So Kendall's about to take it back over now because I haven't trained them on those palpation exam techniques.
Okay, can you just sit up for me?
You got your timer set? Go ahead, get your timer set. This is in the clinic. This is real deal.
Alright. I want you to hold this position. You're gonna open and close your hands for 3 minutes and just continue to do that. I'll tell you when to start. Alright. Go ahead and start. Alright, good.
All right, what do you feel, Megan?
My fingers were tingling. My shoulders didn't like hold my arms up for that one.
You said what?
My shoulders didn't like holding my arms up for that one.
Okay. All right. Now, what's another test we can do for thoracic outlet syndrome? So let her rest for about 2 minutes and then do that one. So passive range of motion, so far, I'm gonna say, unremarkable. With exception of bilateral internal rotation, which could be her normal, but I'm gonna say abnormal. Firm and feel due to posterior capsule tautness and posterior ligaments. Active range of motion. Within normal limits. Noted hypermobility. Hypermobile with most active range of motion, except with bilateral internal rotation. Okay, those were not hypermobile. So exception, bilateral internal rotation. It matches up. It's matching up. All right. Now, MSTT, she was strong and non-painful, right? When she did manual muscle testing, no pain. So she had healthy rotator cuff muscles. All right. So they were strong. So now, we did what? Special test. We questionable was what? Clump test. On which side?
On the right side.
On the right side. Any other special test questionable?
The grind test, I think when you did it, you felt
Yeah.
a little bit worse.
Yeah, right grind. So now I'm gonna question glenoid cavity or glenoid labrum. Labrum integrity. Now, what may I do with this if I continue? I may just treat the patient for 6 visits and notate this, and if I still come back with questionable tests on the 6 visits, then I may recommend an MRI if I don't see any changes. But I may see what PT does first. So now for this, unremarkable, and then I'm gonna notate hypermobile. Hypermobile for most of those range of motions. So hypermobile is driving my treatment plan. So I'm gonna say stability training, right? That's my line of thought due to hypermobility. Now, special test, special test, accessory motion. What do we find?
We did the posterior translation for the head, and I said it felt normal with some slight hypermobility.
Slight hypomobility on which side?
On the embossed side, so the right side. Which, with her being hypermobile,
You say it's like hypomobility
yes, I was about to ask.
on the right. Okay. It's like hypomobility,
With that specific one.
right
because-
side. Posterior glide,
Yes.
GH joint, posterior glide. Okay. So now I may do joint modes as an intervention on that. And kind of work those and see what happens. So now,
Does that make sense of, since her internal rotation is limited?
that
Because she's
does,
okay.
that does
She's
make sense,
hypermobile.
cause you want to match up, it should line up. Yep, so that makes sense. With her posterior glide being slightly hypomobile and her internal rotation, she had abnormal firm, so, and hypermobile with most active range of motion except internal rotation. So it lines up with that. That's what you want. It should clinically line up when we're working with our patients, you know. Now, this is what special tests. We say rules, right?
Yes.
What are you gonna consider rules test based off what she reported?
I want to say it's positive.
Positive. Right, left, or bilateral?
Bilateral. She said she felt tingling in both her hands.
Okay. Now, my palpation exam, right? Palpation exam. Positive, I'm gonna say mild, active mild fascial trigger points. And she presented with nociceptive startle response. Whew. Bilateral upper traps. Bilateral scalene muscles. Which one was worse? I'm trying to remember.
The scalings, I think you said anterior.
On which side? I think it was the right side, yeah. Right side was worse. I say right side greater than left side with an NSR. Okay, so,
Right side, SC,
right side what?
SC.
Yep, SCM. So something going on that right side. She also had so right side SCM muscle. What else did I look at? She had decreased
Yeah.
mobility of bilateral pectoralis, pec minor muscles. I haven't showed y'all how to assess those. Pec minor muscles were tight. She had decreased extensibility of the right short head of the bicep brachii. These are problems. She had decreased. She had pain with inferior mold of your ribs, of your first ribs. When I did those, you said it was somewhat discomforting. So she had increased pain with first rib. Y'all haven't been taught that, have you? Rib, inferior mobilizations. Guess what? Decreased first rib, inferior mobility. So elevated first rib, tight pectoralis minor muscles, tight scalene muscles. Guess what all of those can cause? Thoracic outlet syndrome. You see? Those could be contributing to thoracic outlet syndrome. That's why you gotta know how to assess those. Okay? I'm trying to remember, what else did she have going on?
Levator scap.
Levator scap. Increased pain with palpation, so that would go over here, levator scapular muscle, that would be bilaterally. All right, so these are problems, and all of these problems I would address with her. I have to do a lot of soft tissue work with her I have to show her how to stretch these involved muscles. All of these involved muscles on the first day, she's getting a home exercise program. So she's gonna get a home exercise program for stretching upper traps. She's gonna get a home exercise program for stretching her scaling muscles on both sides. She's gonna get a home exercise program for stretching her SCM. I'm gonna give her a home exercise for stretching pec major, pec minor. I'm gonna give her a home exercise program for stretching levator scap. Everything else, when she comes in, I'm gonna do soft tissue work. And since whatever she's doing at home, we're not gonna do in the clinic. I'm gonna follow what she does at home, what I do with soft tissue. I'm gonna follow that with some type of supportive interventions in the clinic. What I come up with, sometimes I'm creative, but it's gonna address the problems that she has. Okay, now let's go with her other thoracic outlet syndrome test.
This is Alan. So, take the L with your arm, palpate the radial pulse. I want you to look that way and extend your head back.
So move her sleeve down so you can get a direct contact.
And I'm just making note if I feel a diminished pulse. I'm gonna do the other side too. So same thing, but look the opposite. Extend your head back. Alright. I could feel it a little bit, but it's not as, like, I would say it's diminished.
Okay. So,
It was very faint.
okay. So she reported neurological symptoms, right? So give us, describe those symptoms you felt going down your arm again. Can you describe those, Megan? How would you describe them?
Especially after like knitting for a long time, it's just like a sharp burning pain down to the.
Okay, all right. Now, I'm not done yet. Okay. You have any, so you say you had neck problems, right? Okay, so look at me. So move your right ear to your right shoulder like so. All right, any pain, discomfort with that? All right, come back up. Any pain radiating down to your arm with that? All right, same thing. Any pain, discomfort with that? All right, rotate to the right for me. Rotation looks good. Rotate to the left for me. Any pain, discomfort with those? Look back and look up as you're looking towards the ceiling. I'm just doing a quick screen of circle. Any pain with that? Any discomfort? Any pain going down to your arm with that? Okay. Now, come right here. Let me know if you have any pain or discomfort with this.
Yes.
What do you feel?
Like you're crushing me.
You feel like I'm crushing you. All right. Now, with me feeling like you crushing you, where did you experience the pain and discomfort? Just in your neck?
Mm-hmm.
All right. Come right here.
Same thing.
Just in your neck.
Mm-hmm.
Okay. All right. Relax for me. Any pain, discomfort with that? No. Okay. All right. Now, any pain, discomfort right here? How about right here? Okay. How about right here? Okay. Anything right here? Anything now? No. All right. So I did a compression test, distraction test, and I did Spurlins. Why did I do Spurlins?
No vertebral artery.
So Spurlins, she reported no ridiculous symptoms. She reported pain localized to her neck, but nothing ridiculous. So I just quickly ruled out nerve root pathology. Just that quick. I'm using 45, you done good together. So now I have a clinical impression She came in with her subjective report. She did say she's been diagnosed with thoracic outlet syndrome, but we want to go through the workup to see if that's so. So I would have a clinical impression that she does present with signs and symptoms of thoracic outlet syndrome. Likely due to musculoskeletal reasons that we could address in the clinic. Yep. So that's what we think. So now what has to happen, Megan? Now you have to have the problems addressed. So now you got to have a lot of soft tissue work and stretching of those soft tissues and strengthening of those soft tissues as well, you know, to maintain strength in those. So that's a whole nother session, okay? But what I want you to do is take a picture of that right there and email it to me, and then we'll work on getting you some home exercises and teaching you some home exercises that you can do to address those problems for thoracic outlet syndrome. Typically, they will resolve, but you will need a couple of manual therapy sessions. So, we'll see if we can get you in some manual therapy sessions. I don't know how it's gonna happen. We're running tight right now. So we gotta finish the knee and the ankle, but I'll see what we can do, okay? Any questions for us?
Why was my right shoulder like was that from?
So with the clump test, there's an impression that you may have some venoid labrum integrity issues. So if you dislocated it back when you thought you did, that could be problematic and could be causing some of the issues. But as you strengthen the area and work on some stability exercises, that should resolve. So I would stick with a strengthening program, and that again, that'll have to be developed to see if that subsides.
Well, I've been to physical therapy,
And-
16, 17. I've gotten Botox back in
Okay, so repeat. So Megan just told me, gave me some valuable information. So can you turn around and tell the class what you just said, Megan?
I've been to like 8 physical therapy prescriptions since 2015, and with my neurologist I got Botox injections. I did 4 rounds of that over 9 months to get rid of the trigger points, and none of it really ever helped. And I used to play lacrosse, and I did the home exercises on top of the conditioning we did for that, and they still said I wasn't strong.
And so what interventions did the physical therapist do? This is what I would want to know.
They did dry needling
Okay,
and mobilization, manual injection.
okay. Did they do any soft tissue work on the structures that we found that were problematic? Did they do any soft tissue on your upper trapezius?
I think so.
Did they do any soft tissue work on your scalene muscles?
I don't think so.
Did they do any joint mobilization on your first rib? Did they do, I'm asking all this because I need to know what I'm gonna do that they didn't do that is different, okay? Did they stretch your pectoralis minor muscle?
I mean, they have me sit in the doorway.
Okay, all right. Let's see. Did they address your levator scapular muscle?
Maybe, I don't know, they didn't say it directly, they had me do like.
That's levator scapular stretch. Okay, yeah. So they had you doing everything that we would give you in a home exercise program. So that's good. And so basically, I think what I would do is different. I would probably do more soft tissue work and follow that soft tissue work with supporting interventions like specific exercises. Have you doing exercises that mobilize those muscles after the soft tissue work. And when we're mobilizing the muscles, it's gonna be strengthening them, concentrically strengthening muscles and eccentrically strengthening muscles simultaneously. That's the component that I would add. Did they have you doing, for example, scapular retraction? Okay, so we're on point with that. So they had you doing a good bit that could be beneficial for your condition. It's just a few minor things that I would probably add. well, I ain't gonna say minor, major things that I'll probably add that they probably missed out on. All right, that's it. But yeah, but in regard, I want to make sure I answered your question. In regards to your shoulder, I would have a clinical impression that you could have some glenoid labral pathology. But what I would do, I would implement a stability strengthening program for your shoulder joint complex, rotator cuff muscles, and also scapular muscles, and work that strengthening program. And if you still present with that, like 6 visits later, then I would recommend an MRI. Because you did have some pain with one of those tests. But it was on a scale of 0 to 10, what would you rate that pain? Like a 3 or 4, so not much. Okay. So, yeah. All right. Any questions for us?